All right, let's dive right in. We're talking about something that happens on the absolute razor's edge of life and death, vascular trauma. This is really a story about one thing, stopping the bleeding. It's a race against the clock that has forced medicine to evolve in some pretty incredible ways.
So why should you care about this? Well, here's a stat that might stop you in your tracks. For Americans between the ages of 1 and 46, what do you think the #1 cause of death is? It's not cancer, it's not heart disease, it's trauma.
And when you look closer at these tragic cases, you find something really important. Most of the time, it's not the initial injury that's fatal, it's the bleeding. Uncontrolled bleeding, or what doctors call hemorrhage, that's the real killer. So that begs the big question, right? If stopping the bleed is everything, how in the world did we get so good at it? And the answer is pretty fascinating. It wasn't figured out in some pristine, quiet hospital. Nope, these lessons were learned in the heat of battle.
Okay, so first things first. Let's really wrap our heads around just how big of a deal this is. Before we talk about the fixes, we've got to understand the true cost of trauma. Because honestly, that context changes everything. When you break it down, vascular trauma is brutally simple. Think of your body's circulatory system as a complex network of plumbing. Vascular trauma is just a leak, a really, really bad one. A busted pipe, an artery, or a vein. And when that happens, you get massive, rapid blood loss. We're talking about a problem that isn't measured in hours, but in minutes, or even seconds.
Now look at this number, 31.7%. That's a big number, but what is it? It's not a death rate. It's actually the percentage of all years of potential life lost in the US that are due to trauma. Just let that sink in. It's a way of measuring all the birthdays, the graduations, the contributions to society that never happened because a life was cut short by injury. It's just a staggering cost.
Okay, so how did we learn to fight back against this? Well, almost everything we know today comes directly from a pretty grim source, war. For over 100 years, the battlefield has been the ultimate high-stakes testing ground for vascular surgery. You can see the whole story of progress right here. Back in World War I and II, the go-to move was just to tie off a bleeding artery. It's called ligation. It might save your life, but you'd very likely lose your limb. Then, a huge leap forward during the Korean War. Surgeons started focusing on repairing the vessel. Game changer. By Vietnam, we got even smarter, creating a vascular registry to track every injury and learn from it. And then, in the recent conflicts in Iraq and Afghanistan, the goalposts moved again. The mission became saving not just life, but life and limb. And this quote from back in 1946, wow, it really drives the point home. Out of almost 2,500 major arterial injuries in World War II, doctors only even tried to repair 81 of them. The standard procedure was just to tie it off and hope for the best. And the result? A 36% amputation rate. That was just the price of survival. And look at the difference that shift made. It's right here in the numbers. The amputation rate plummeted from 36% in World War II all the way down to 13% in Korea. That's not just a little better, that's a full-blown revolution in medical care. All because of one idea: repair. Don't just tie off. Let's put it side by side. The difference is just night and day. In WW2, you had ligation. In the global war on terror, you've got advanced tourniquets and shunts to stop the bleeding right there on the spot. The goal went from just make it out alive to we're saving your life and your leg. And the tech? We went from basic surgery to these amazing endovascular techniques where surgeons can go inside the blood vessel with tiny wires and stents to patch things up. Absolutely critical stuff when dealing with the kind of complex injuries caused by IEDs. But, and this is a really big but, despite all of these incredible advances, we have to face a hard truth. When you look at the combat deaths that we think were potentially survivable, a huge number, we're talking 80 to 87%, are still from one thing: hemorrhage. They're bleeding out on the battlefield before they can even get to a surgeon.
So you might be thinking, okay, that's intense military history, but what does it have to do with me? Well, everything, because these innovations, learned at such a high cost, didn't stay on the battlefield. They came home. They are now the absolute foundation of emergency care in every city, saving lives after car accidents, workplace injuries, you name it.
Think about what happens in a top-tier trauma center today. So many of the key tools in their toolkit were born from military necessity. The tourniquets that paramedics and even police officers carry now, that's a direct lesson from the battlefield. The whole idea of damage control surgery,
where the goal is just to stop the bleeding fast and get the patient stable, saving the fancy repairs for later, straight from the military playbook. And those high-tech endovascular fixes with stents and balloons, yep, you guessed it, all of it translated directly from the war zone to your local ER. All right, so we've covered the amazing how of treating these injuries, but now we need to talk about the who, because when you dig into the data, you start to see some really tough patterns, things that point to some big challenges within our healthcare system itself. Take a look at this. It's pretty shocking. Researchers looked at people who had basically the same kind of penetrating leg injury. The only major difference? Whether or not they had health insurance. For insured patients, the mortality rate was about 21.5%. For uninsured patients, it jumped to 31.7%. That's a 10-point difference for the same injury. And it doesn't stop with insurance. The research shows that even when you control for how bad the injury is, a patient's race is still an independent predictor of whether they live or die. Now, that is a deeply complex and disturbing finding, and it tells us there are issues at play here that go way beyond what happens in the operating room. So where does that leave us? This brings us to what might be the most important part of this whole story. We've become incredible at treating these injuries. So what's the next big leap? Well, it's shifting our focus from treatment to prevention. It's about declaring war not on the bleeding, but on the injury itself. And the main tool for this new fight is something called epidemiology. Now, you've probably heard that term in relation to things like the flu or other diseases. It's the science of tracking how health problems spread through a population. The really revolutionary idea here is, what if we treat trauma like a disease? What if we use those same tools to track this man-made problem?
And here's the game plan. Step 1, you gather a ton of data. Who's getting hurt, where is it happening, and why? Step 2, you look for patterns. You find the hotspots, the risk factors. Are there certain intersections where crashes always happen? Are specific groups more at risk? Step 3, you intervene. You use that knowledge to create targeted solutions, whether that's better street lighting, a public safety campaign, or a new policy. And step 4, the whole point of the exercise, you prevent the injury from ever happening. You move the fight from the operating room out into the community.
And that really brings us to the big takeaway. The next massive breakthrough in this field probably isn't going to be some fancy new surgical robot or a miracle drug. The single greatest opportunity we have to save lives is to stop the injuries from happening in the first place. So, for the last 100 years, we've become absolute masters at putting people back together. We can save a limb that once would have been lost. The question we have to ask ourselves now is, can we take all of that focus, all of that genius, and become masters at preventing the injury from ever happening at all?